Full screen now.
Perfect. Okay. So these were slides forwarded to me by Chris Parker, who I think is also a member of the Scientific Advisory Committee for your Picasso group, isn't he?
Yes, he is. Yeah.
He very kindly shared these slides with me, and I'm not going to show all of them, but I'm going to skip through to show you some of the interesting ones, because this has been a really important trial in terms of how we look after patients when they have had an operation for their prostate cancer. So now we're talking about a slightly different group, and just to make it really confusing again for Charles and everyone else, there are so many different options for people right at the beginning when they're first diagnosed. And one of the options is that they get a surgical removal of the prostate rather than brachytherapy or external beam or anything else. But the patient group that we're looking at in this trial are patients who have had a radical prostatectomy. They've had a surgical removal of their prostate gland. And the trial was trying to answer the question, do you need to give radiotherapy straight after you've done an operation to try to reduce the risk of the cancer coming back if that patient had some, inverted commas, high-risk features? Or can you watch them really, really carefully, watch their PSA, and then give them what we would call salvage radiotherapy if the PSA starts to rise? Historically, there were two other trials which had tried to answer this question, but they were very, very conflicting, and they were much, much smaller trials than Radicals ended up being. So Chris et al. Thought, well, let's do a really big trial and try and answer this question for good and proper, but also in a more modern era when we have super sensitive PSA assays. So we've got blood tests where you can pick up a PSA at 0.01 or 0.02, so at very, very low levels. And so the trial was, I'm trying to get rid of, there we go, that's better. I'm trying to get rid of my face. I can only see Roger now, that's lovely. Roger and the full screen. So this is the trial design. So these are patients on the left. So they had a radical prostatectomy, and straight after their prostatectomy, we want their PSA to have gone under 0.2. They were entered into the trial anytime between 4 or 22 weeks after the operation. And to be eligible for the trial, they needed to have had one or more of these features on the left here. So either a T3 or T4 tumor, which means it's poking outside the capsule of the gland, or it's got to be a Gleason 7 cancer or above. So Gleason 6 on its own was not an eligibility. If their PSA before their operation was greater than 10, then they were potentially eligible. Or if they had a positive margin of excision, in other words, when the surgeon did their operation and they put their knife around the tumor and gave it to the pathologist, if the pathologist said the tumor went right up to where you put the knife, then that's referred to as a positive margin. And there's a concern, obviously, that there might be some cells left behind. And then the randomization in the trial, so they randomly allocated patients to either radiotherapy straight away, known as adjuvant radiotherapy, or they were randomized to what we call salvage radiotherapy. So that's radiotherapy given if they had PSA failure. And PSA failure was defined as a PSA of greater than 0.1, and then it must have risen on 2 occasions, or it rose 3 times in a row, and it could be of any value at all. So it could have even been 0.05, 0.07, 0.09. So super low levels here, but 3 rises in a row, and then that constitutes a, inverted commas, PSA failure. The outcomes of the trial were to look at a number of different things, but in the presentation that they gave, they didn't have data on overall survival. So we were looking at PSA results and freedom from progression, which is the phrase that's used frequently in this context. They also looked at freedom from starting hormone therapy, which is often an indication that the clinician looking after that patient has concerns that there is recurrence. Now, I'm going to skip down through some of the statistics, but the definition of biochemical relapse after they've had their treatment, so in other words, in the adjuvant group, if they had their radiotherapy up front, if their PSA after that ever got to a value of 0.4, then that was defined as a recurrence. If the PSA was greater than 2 for either group, that was also defined as a biochemical recurrence. patients from all over the world, mostly in the UK. This is the baseline characteristics table that they always give, which basically shows that because it's a randomized trial, the facts and figures about the patient's cancers were basically identical, because you've got 700 patients in each group, so a very large trial, average age 65, PSA at diagnosis almost exactly the same, 7.88, that is the median. And then all the features about the Gleason score, the T stage, the margin positivity, they're all almost identical in both groups, which is what you get if you've got very large numbers of patients going into a truly randomized trial. I'm going to skip down now to the take-home message. So this is biochemical relapse leading right out to 8 years. So this is the number of patients who've had a biochemical recurrence. In other words, the PSA has gone up to a level which we have then labeled it as calling it a biochemical relapse. And it's going right out to 8 years from going into the trial. And as you can see in that time frame, if I can wiggle my mouse appropriately, this number of people here have had a recurrence, but this number, so over 80%, are still in remission. So 80% of the patients who went into this trial were still in remission 8 years on, and that's whether or not they got the radiotherapy straight away or whether they got radiotherapy when the PSA started to rise. And that's the key message. Basically, there's no difference in those two curves. And then if you start looking at the clever statistics, you look at this thing called the hazard ratio. And if the hazard ratio crosses 1, then it means there's no difference in the two groups. And this is going from 0.8 to 1.4. So it's plumb over 1, which means there's no statistically significant difference between these two groups. And the same is true for this another measurement, which was freedom from non-protocol hormonal therapy, which is, in other words, where I said that the patients were started on hormonal treatment by their clinician because they had concerns about recurrence. And basically the two lines overlap again, and that means there's no difference at all. So basically this is good news in terms of the fact that we think it is entirely safe to not give radiotherapy straight away after an operation, even if they have 1 or 2 of the high risk features, because the salvage radiotherapy option is just as good as giving them radiotherapy up front. And what you're also managing to do then is to avoid over giving radiotherapy, because although I'm obviously a radiotherapy doctor and I recommend it and give it to an awful lot of people, if you don't have to have it, then that's a good thing. And we don't want to give it to people who are not going to get a recurrence. And in that group of patients who had high-risk features at the time of diagnosis, some of them will never get a recurrence, but you just don't know which ones at the start. So if we can avoid giving them that treatment, because we've now proven that we can give salvage treatment, which is just as effective, then that's a much better option. So I would say, I'm just going to skip down. Yeah, I don't think there's any other bits on that slide that I wanted to share, but I would say that that has been a practice-changing paper, in as much as it's allowed us to stop giving adjuvant radiotherapy straight after surgery to patients, even if we felt that there were 1 or 2 features which made us slightly anxious that we needed belt and braces treatment. Okay, I'm going to pause again so I can have a swig of water. And again, well, let's do the same thing about the questions if you want. So if you go back to participants and put your hand up and then unmute when I say your name. So David Griffiths. Can't hear you, David, if you are.
I'm here. I'm just struggling to find my unmute button. Thank you, Angus, for that. Just a quick, I'd never heard of this as an option before. I had radical prostatectomy back in 2013, was diagnosed with metastases in April this year. But does this suggest that possibly I might be a candidate for radiotherapy now?
So it depends on what they're referring to as metastases, because if you've been unlucky enough that it's come back and it's spread to other places around the body, then radiotherapy to the pelvis is not going to be beneficial. The radiotherapy to the pelvis is for the patients where we think that the reason that their PSA has risen is because the recurrence is within the pelvis, in the area which we call the prostate bed. So going back to those CT scan slices I showed earlier on, it would be that sort of region that we would give the radiotherapy to. But
mine is in lymph nodes in the prostate bed.
Yeah, but if someone gets a recurrence which is out of that field or in the lymph nodes higher up outside the pelvis, or even further afield around the body, then that radiotherapy wouldn't be beneficial.
Okay. But as far as I understand it, I have lymph nodes that are active in the prostate bed and also something in my spine at C3. It sounds like that one wouldn't be, but the ones in the pelvic area might be.
Yeah, so then it's a question, I'm not sure where you're being looked after or treated, but then it would be a question of whether or not the one in the spine could have some radiotherapy as well as treatment to the pelvis, or whether there was a consensus that unfortunately there's too much evidence of disease outside the pelvis to render a long course of treatment through the pelvis not being helpful and potentially side effects.
There has been discussion of having the one in the spine having radiotherapy, but not of the others. So.
Okay.
Anyway, okay. I'm at Brighton and Sussex. So.
Well, it might be worth asking that question. Yeah. So you can, so you could have we're branching off onto a different topic here, which is what's called oligometastatic disease. So oligometastatic disease refers to disease which is secondary. In other words, it's not local anymore. It's secondary to distant places, but there aren't very many of them, or hopefully there's just one or two. And if that's the case, then there is increasing evidence that another form of treatment, such as stereotactic radiotherapy or high-dose radiotherapy of some form to that distant secondary, would be of benefit. And as I've just demonstrated, we know that radiotherapy to the pelvis is of benefit if people get recurrence within their pelvis.
Sure. No, thank you. That's really helpful and heartening. Thank you. I'll follow that up.
Okay.
Robin's got his hand up.
Has he? It's not appearing on my chart.
Put his physical hand up.
Oh, a physical hand. I can't see physical hands. Yeah, fine. Thank you for being the extra chairman, Cliff. Robin.
Yes, I had brachytherapy in 2013 up at Guildford, and they did that for me because they couldn't get to have radiotherapy. They couldn't get my bladder pushed out of the way, and they said they would it would damage it. So I had the brachytherapy. And my PSA ever since has been 0.01.
Great. Great. Yes, you brought up another interesting fact. So I was talking about the group that we treat down in Sussex, mainly being the ones with high risk disease, where we're giving them a boost to the prostate. But actually, there have been a few cases where we've looked at their planning scan. They were going to just have external beam radiotherapy, and they've had their planning scan done, but it's demonstrated that just because of their anatomy being slightly different, a lot of small bowel has dropped right down behind the bladder on top of the prostate. Now, small bowel doesn't cope very well with radiation. Bladder copes fine, large bowel copes okay. But if the small bowel is dropping down and very close to the prostate, it is going to get a meaningful dose during external beam. And that makes us a bit anxious. So for those patients, on a couple of occasions, we've then converted them, even if they weren't particularly high risk, we've converted them to giving a much, much lower dose with external beam, but we've boosted the dose to the prostate with the brachy because of this feature that the dose from the brachy is very confined. It doesn't then spread outside the prostate to the bowel. So it's a good way of minimizing the dose externally. So thanks for that.
I feel that I've been very fortunate.
Thank you for that. Stephen Tutton's got an electronic hand up, and I'm sure someone will tell me if there are any more physical hands. Stephen.
Thank you for the presentation. It's very informative. I had testicular cancer 36 years ago and had 18 sessions of radiotherapy. Now there's a doubt as to whether I've now got prostate cancer. I've had on hormone therapy and chemotherapy. Would there be any reason not to have radiotherapy in view of the previous radiotherapy?
So you're not under my care, are you?
Sorry?
You're not under my care?
No. Kiwi.
There is I have got a gentleman in a very similar position to you, in fact, who had radiotherapy for testicular cancer 30 30 years ago.
Yeah.
And for exactly that reason, we have elected to go down the combination external beam and brachytherapy route, because we wanted to reduce the dose of the external beam radiotherapy because of the concern that the previous radiation from the testicular cancer combined with the up-to-date radiotherapy was going to end up with too much bowel damage. So I think it's a very real question that you should ask. Obviously, I can't comment about the extent of your disease, the grade, the PSA, the you know, what's been found on imaging, and that's the thing you need to discuss with your clinician.
Yeah,
So
I had two Mets, one on my arm, one T5, which halfway through the chemo I had an MRI, and they had disappeared. I know that's not a, well, they're smaller.
That's great. Well, if they were definite secondaries,
Yeah.
And they are responding, then that's clearly good news. Now, whether you go down the route of this treatment of oligometastatic disease that I referred to 2 questions ago,
Yes.
which is it possible for someone to give some high dose treatment to the 2 lesions in the bone, the arm and the spine, as well as some radiotherapy to the pelvis? I don't know.
No.
You're then talking about more and more and more radiation, so you just have to be a little bit cautious about how much you can give. Yeah. I mean, we certainly think that radiotherapy helps a lot, and I'm sure many of you have heard about the Stampede clinical trial. If I can digress again briefly before we go on to John Kempshall. The Stampede trial has looked at multiple different options of drug treatments and combination treatments for people with advanced disease at the time of presentation, and probably the reason you're getting chemotherapy at the moment,
Yes,
because of the results of that trial. One of the newest versions of the Stampede trial is going to include an arm looking at radiotherapy to oligometastatic disease. So if people have got 1 or 2, maybe 3 isolated spots of secondaries somewhere else around the body, then the plan potentially is to give radiation to all of them and to the prostate, as well as the hormones, as well as the chemo, as well as blah, blah, blah. So yeah, it's a real question that should be asked, I think.
okay, thank you for your answer. Thank you.
John Kempshall.
Dr. Angus, can you hear me?
I can.
Very interesting Zoom, thank you. I had a radical prostatectomy 12 years ago, and I was left with a positive margin. I've since had metastasis into my lymph nodes in my pelvis, where there are apparently 5 tumors, 1 large and 4 small. I've investigated a thing called cyberknife, which I don't think you've mentioned. And also, I'm wondering whether I should investigate immunotherapy. Would you care to comment?
So if this is a new diagnosis of relapse in the lymph nodes in the pelvis, then my recommendation would probably be that you have hormonal treatment plus radiotherapy to the pelvis, including the lymph nodes, once the lymph nodes have shrunk down a bit with some hormone treatment. Cyberknife, the advantages of cyberknife are when you've got a small discrete lesion on its own. If you're treating a range of lymph nodes or a lymph node field, it wouldn't be of any benefit, and you'd need intensity modulated radiotherapy. So I don't think cyberknife would be of help. As regards immunotherapy, there's absolutely no evidence of the benefit of immunotherapy in any stage of prostate cancer yet. So no, I wouldn't be recommending that if you were under my care. Now, that's not to say it shouldn't be looked at in a trial setting, and increasingly it is, but there are many more proven treatments in prostate cancer which are more advantageous.
I had salvage radiotherapy straight after the radical. So I can't have any more radiotherapy down there.
Okay.
But I'm being kept going very well on enzalutamide.
Okay.
I just wondered if there was any other scope. Presumably I shall move on to chemotherapy as and when necessary.
Yeah, so there's a few other options there for you, including chemotherapy and including some of the novel treatments like the PARP inhibitor, which we haven't had a chance to talk about tonight. But I certainly don't think immunotherapy is going to be the option currently. And it sounds like you're doing very well on the combination of drugs that you're on, so that's good news.
Indeed so, yes. Thank you very much.
Any other physical hands? I can't see any other.
I can't see any.
Okay. So is it supper time then?
I think so.
Oh, Roger's got a hand up.
Yep.
He's allowed to ask a question.
Yeah, I'm wondering where the hormone therapy fits in with radiotherapy, because in a lot of cases now I've heard that radiotherapy patients are also getting a bout of hormone therapy.
Talking about in the salvage setting after surgery, aren't you?
Is that in only for salvage or just for straight?
Right. I wasn't sure which group you were asking about, because there are so many groups who get radiotherapy, obviously. So,
Right, regular people that are going for radiotherapy.
yeah, so I'd say still the vast majority of people who are getting external beam radiotherapy or external beam radiotherapy and brachytherapy combined would all get hormonal therapy. The sort of low intermediate risk group who are getting implant brachytherapy as a monotherapy as their only treatment, they're often so low risk that they don't need it. But we don't do those down in Sussex. They go off to Guildford, as you probably know. So the groups that we treat with brachytherapy, they all get hormonal therapy, but that's partly also because they're mostly higher risk groups who definitely benefit from hormonal treatment. What I thought you were also hinting at was the question about the role of hormonal treatment in the salvage setting. So, and this is a bit more controversial and interesting. So I've described how salvage radiotherapy is just as good as adjuvant radiotherapy, and therefore we don't need to give adjuvant radiotherapy anymore. And then there is some data to say that if you give hormone treatment at the time of salvage radiotherapy to the prostate bed, that can be beneficial for patients. The problem is they are slightly old trials, and the PSA, they let the PSA get to quite a high level before they went into the trial, much, much higher than the level that we now say, oh, it's time for you to have some radiotherapy to your prostate bed. And so we don't routinely give hormone treatment to everyone who gets salvage radiotherapy, I suppose is my summary of that. Right. But if there are some people who, for whatever reason, they've got lost to follow up, or they've had a very rapidly rising PSA many years after surgery, and the PSA is 2 or 3 or 5 or something, then I would give hormone treatment as well as radiation. If it's only 0.2, 0.3, then I don't. I just give the radiotherapy.
Would there be a reason to give hormone therapy if the prostate was particularly enlarged? Because obviously the hormone therapy shrinks the prostate. It
does a bit. It's never, and it would have to be GnRH analog hormonal therapy, not bicalutamide or an anti-androgen. So yes, that has been done in some cases. I've never been overly convinced it does it dramatically to the actual prostate. It shrinks the lymph nodes really nicely if they're affected. But if someone's got a really big chunky prostate, they're probably still going to have quite a big chunky prostate even after 6 months of hormone treatment.
Right.
But it's worth a go.
Yep. Thanks.
We've got another hand up with Derek Pilling.
Okay. Derek. You're muted still, Derek, if you can reach the mute button. Well done.
Sorry, I had radiotherapy in 2004, and 5 years later had HIFU treatment, which is a whole blast of HIFU, not the ones they do now. And that recurred in 2013. And that was specific to direct the HIFU treatment at where they knew the cancer was. And since then, after the HIFU treatment, I was about 0.01. And then gradually, over the last 5, 6 years, 7 years nearly now, it's gotten up to 0.7. It's been going up gradually, 0.1, 0.2, 0.01, 0.02, and right the way through some now 0.7. Does that fit into your biochemical relapse that you're talking about?
Yeah, it probably does. The problem is you're probably struggling for local treatments to the prostate again now. What would probably be done is a repeat scan of some description when the PSA reaches 1.0. Yeah. Have they suggested you can have any more HIFU or not?
They did at one time say I could, but they've been having second thoughts about that.
Okay.
My prostate is actually only down to 2.5 centimeters cubed. It's very small now with all the treatment.
And you run the risk that repeated HIFU treatments can leave not inconsiderable side effects with sort of
That's right.
healing. And
it's not metastasized, thank God.
No. So I think with a very, very slow rising PSA, we would probably sit tight and do nothing. If it gets to 1 or above, you might start exploring the possibility of some fancy new scan of some description, the best one being the PSMA PET scan, if you can access it. And if that shows nothing, I'd still sit tight and just watch it. And eventually you might get to a point where we go, okay, a short course of hormonal therapy will bring this right back under control, even if it's just 3 or 4 months, switch it all off again, and then you start.
Well, I'm concerned with hormonal therapy because it affects my voice. I had a tablet before the radiotherapy, 150 gram, can't we cut cuddies?
Glutamide, probably,
yeah. It was just a small tablet that I had for 6 months, which reduced the size of the prostate. So that was it in actual fact.
Well, it certainly sounds as though nothing needs to happen quickly at the moment if it's a very slow rise.
Well, thank you for that. I said it would be quick.
Oh, a couple more have appeared. Tony Ball.
Yes, Angus, please. I just picking up on you mentioned PSMA imaging a moment ago.
Yep.
And you said difficulty in accessing it. What's the likelihood of that becoming more available through the NHS in our region? I believe it's just up in London on a trial at the moment.
Yeah, I honestly don't know the answer to that question in terms of likelihood, percentage chance over the next 6 months or year. It's certainly something that the nuclear medicine team are working on hard to try and access, but I can't tell you when we're going to get it much more freely available. We do have locally choline PET scans, which are also extremely good. And we are sending a lot of patients for choline PET scans at the moment. And we've got a very quick service in the PET scanning department down in Brighton for that.
Yeah, I had that about 3 years ago at the university.
Yeah.
Falmer, isn't it?
Yeah.
Is it the machinery that, is it just a question of the isotope then, or is it the same equipment that delivers it?
It's the same. It's produced in a different way. So my understanding it's the creation of the isotope which is the issue. I think the scanning is the same once you've had the injection.
Right. Thank you.
Alan Taylor, Isle of Wight, as opposed to all the other Alan Taylors.
Okay, can you hear me?
Yeah.
Okay, good. Right. So I had my prostate removed in 2011, 2012. I had salvaging radiotherapy. 2016 it returned, and I was put on to hormone treatment for 2 years, injections, taken off of that after 2 years, and put on to biochemical for 2 years. And now I have a rising PSA and being put on to back onto bicaltamide, but I now have pelvic pains which have put me. I've been in for an MRI, but there's a delay in what's happening with that because there's an increasing amount of COVID on the Isle of Wight. What could be the next stage?
Well, you need those scans done, don't you? You need to find out why you're getting the pains, to find out whether there is any further recurrence. If you're just on bicalutamide at the moment and not on hormonal injections, and you do have recurrence, then you're probably going to need to go back onto the hormone injections to switch off testosterone production. And then I don't want to predict one way or the other, but there are a number of different options if recurrence is found. Particularly actually since COVID's been around, we're allowed to prescribe enzalutamide in combination with GnRH analog injections for newly diagnosed metastatic cases. So if you were unfortunate that secondary disease was found, then in addition to going on to the GnRH, it would be going on to enzalutamide as well, probably.
So enzalutamide is better than an abiraterone?
It's the one that we can access, and I think probably it is better. It's easier, it's better tolerated, and you don't have to take steroids with it. And there are slightly fewer side effects. I think they're probably equivalent in their effect, if we're completely honest.
Right, thank you very much.
Okay.
That exhausted the questions. Nobody else?
We're there.
Okay. Well,
Lovely. Thanks, Roger.
that's great, Angus. I think people have got a lot out of that, and thanks for taking the questions as well, because they've all been very interesting and hopefully helpful to a lot of people.
Yeah, I hope so. Yeah, no problem at all.
Thank you very much for your time, for taking part. Yeah, everyone can give you a round of applause. Yeah, if you want to unmute yourselves. You muted me again.
Don't be shy.
Thank you very much.
I forgot, but we obviously, there weren't just Picasso members on this Zoom. There were members from the Isle of Wight group, as you obviously gathered, and there were a few members from the Mid Sussex group as well. So you've been talking to 3 different support groups there. Okay, I think you're still you're muted now, Angus.
Oh yes, sorry.
Okay.
So I was just saying the wonders of modern technology. We can do these broader and broader regions, can't we?
Well, this is it. I think we'll be doing more of these Zooms next year as well, because it doesn't matter where people are. The geography can be spread far and wide, so it gets to more people. And we've had a good number on the Zoom tonight. So I think we will be continuing the Zoom meetings even once we're out of this COVID situation.
Good stuff. Well, thanks very much, everyone, and stay well and free of infections.
Thank you. Thank you very much.
Thank you very much.
Thank you very much. Bye.
Bye.
Thank you. Bye-bye. Thank you.
Okay, thanks everybody for coming on. Hopefully everyone have a good Christmas. Now we're allowed 3 different families involved. And we'll see you all again in the new year.
Thank you, Roger.
Thank you very much.
Roger.
Thank you. Yes, thank you, everyone.
Thank you for the invite, Roger.
Thank you, Cliff.
Bye.
Thank you, Cliff.
Thanks, Cliff.
Yeah, thank you.
Ooh, the numbers are going down. Right. Yeah. Bye, everybody.
Bye.
I'll leave now.
Right.
Right, we're nearly there. Thanks, Cliff, for doing that. Did you manage to get it recorded?
Yes.
Yep. Let's see what.
I'll check it out later and see.
Check it out. Yeah, let me know.
Yeah. So I can end the meeting, but I'll see when everyone else is shut down. Okay.
Yeah, good. Okay, be in touch.
Yeah. Bye.
Bye.